So we're just going to give folks a few seconds to filter in. It's nice to see everyone, to be together in 2021. Welcome to the Gender Equity Education Series. As many of you know, I'm Ann Doherty. I'm the Gender Equity Liaison here at the College of Medicine. And today we're so excited to have Dr. Julie Silver with us. She is an expert and a true advocate for gender equity in the workplace and specifically in academic medicine. So it's a real honor to have her with us today. There are just a couple of housekeeping pieces that I want to mention. One is that I often get questions about whether the sessions are being recorded. I realize that we have so many meetings going on, lots of conflicts. The sessions are being recorded. You can go to the ODEI website and click on the video library link. So it's med.uvm.edu/diversity inclusion and then video library. Pass that along to your colleagues. The other thing I want to mention is that March 4th will be our second celebration of gender equity in medicine and science. This is a great celebration to recognize those in our institution who are doing great work in medicine and science and also around gender equity. There was a call for nominations for our awards that went out this past week. The deadline is January 15th, so please check your email for that. And then, you know, a lot of times we have this question of, well, how are we going to do this work? How do we get from point A to point B? How do we really move the needle? And I'll tell you that the answer is that we're going to do it together and that we're going to do it with shared vision and purpose. And with that, I just want to take a moment again to recognize the Dean of our college, Rick Page, who truly shares this vision. And I'll give him an opportunity, Dean Page, to say a few words.
Thank you very much, Dr. Doherty. I look forward to these sessions and look forward to the opportunity to say a few words to the community. Yesterday was a painful day in some ways, and I actually sent a note to the Larner community about that. Nevertheless, I remain hopeful for the future and hopeful for our college, especially as we adhere to our core values, and our core values including professionalism, cultural humility, treating everyone with kindness and respect, true inclusion and equity among our staff, faculty, and students, and a maintenance of an effort toward diversity in all we do and for students, faculty, and staff. So part of that, and part of the reason I'm enthusiastic is thanks to Dr. Doherty and others in terms of the emphasis, in terms of her role as liaison for gender equity, for the working group, for our Office of Diversity, Equity, and Inclusion. And along that line, I will confess some selfishness in that I get to carve out an hour and learn something and become better informed thanks to the tremendous quality of the speakers that Dr. Doherty and the group have been asking to join us. And a byproduct of this crazy world we're in is that we can have people from places like Boston spend this time with us without having to travel. And we are able to record these sessions and have them available afterwards, although we have a good crowd, 61 participants so far, which is terrific in real time. So my greetings to all of you, my thanks to Dr. Doherty, my thanks to Dr. Silver, whom I just met. And I look forward to making myself invisible in a couple minutes and sitting back and enjoying and learning from a true expert and someone who can help us reach our aspiration, our goal, and the point where we will achieve diversity, equity, and inclusion and full gender equity in our College of Medicine. So I'll turn things back over to our leaders here today.
Great. Thank you so much, Dean Page, for your support, for your enthusiasm, and your willingness to learn alongside all of us. Truly appreciated. Now I'm going to pass off the virtual mic to Dr. Jo Conant. Dr. Jo Conant is not only an LCOM, Larner College of Medicine alum, but she's also a member of the Department of Pathology and Laboratory Medicine, and she's also the chair of the Education and Professional Development Working Group from the Gender Equity Initiative. And these sorts of sessions would not go off if it wasn't for Jo Conant. So Jo, take it away.
Thank you, Dr. Doherty. So I am really excited to be able to introduce Dr. Julie Silver. She is an associate professor and associate chair in the Department of Physical Medicine and Rehabilitation at Harvard Medical School. She is on the medical staffs of Mass Gen, Brigham and Women's, and Spalding Rehab Hospitals. Dr. Silver has also developed and directs the successful Harvard Medical School Women's Leadership CME course that has trained thousands of women in medicine. She's a subject matter expert on workforce diversity, equity, and inclusion, and her research often intersects with innovation and implementation science. She has developed a unique approach to workforce inclusion and wellness, aimed at strategically advancing equity and promoting wellness for faculty and staff by analyzing how they are valued and respected for their contributions. This foundational work has recently been incorporated into the American Association of Medical Colleges Gender Equity Statement and Call to Action. So with that, I'm incredibly honored to introduce to you Dr. Julie Silver, who joins us today to discuss accelerating workforce equity, diversity, and inclusion in academic medicine. We will hopefully have time to answer some questions. So if you have any questions or comments, we do have a Q&A function that you can use through Zoom. Dr. Silver?
Wonderful. I'm very excited to be here. Pull up my slides. Thank you so much, all of you, for being here today. I think that this is a really important topic. And in terms of my disclosures, I like to just remind people that the people who are doing the DEI work are often doing this at their own expense. They're often uncompensated, volunteering. Research is generally or frequently not funded, et cetera. So it costs a lot of money to do this work. And I don't have any disclosures related to it other than to say that personally, it's very expensive for me to do this work. I want to talk about just the objectives here, which is really to focus on data and to think like a scientist, identifying gatekeepers and then figuring out how to accelerate things. As I talk about things, I want to just say that I look at this through the lens of gender, and also through the lens, and gender's a spectrum. We don't have a lot of data for the gender spectrum, so it's really important that a lot of research is done binary, but that doesn't, men and women, but that doesn't mean that that's the gender spectrum. That's just the way research is done. We don't have a lot of research on people with disabilities, and we haven't studied a lot on medical staff and so on. So most of the research is gender focused, binary, and focused on women physicians and scientists. And that's really where my expertise is. But I want to make sure that when we think about DEI, that we're being more inclusive. So I'm starting with this study. This just came out in the New England Journal of Medicine. And this is Richter et al. And one of the reasons I'm showing this to you is because people really want to believe that things are better, even when the science shows that they're not better, that it's not better. So in this study, over a 35-year period of more than 500,000 graduates, women physicians did not make progress. In fact, in some instances, they backslid. So it's super important to not believe things that are not true. It's just, there's such a desire to believe that we're doing better in so many different realms when the science shows we're not. That doesn't mean that we're not doing better in some areas. It doesn't mean that a single institution might not be doing better with regards to promotion, but I really, really, really want to emphasize this idea that DEI, we should come to it as scientists and using data and not believe things that are not true. So when we look at this and we think, well, my goodness, why is it that women are not being promoted? Why can't they get to the top? Why can't they be promoted to full professor? And this is a study that I recently did with colleagues that generated lots and lots of talk and discussion and so on about this idea of a citizenship tax. And just before this lecture started, behind the scenes, we were discussing this idea of how we all have patients to take care of, but then we also do these other things, these citizenship duties, rather than scholarly work or patient care. And that slows us down. And that's really, really important. So this study is new. It's the first time that it's really been described in the medical literature, but it's not a new concept at all. I mean, any group you get into with a bunch of women who are professionals, they're going to start talking about the gender tax. And when you think about people who are underrepresented in medicine because they're racial or ethnic minorities, you'll hear about them talk about a minority tax. And this has also been written about, but not studied in the way that we at least started the conversation to study this. So, thinking about this, if we say, wow, we have this problem with getting women promoted, we have this problem with compensation, and I'll talk about that in a little bit. And also people are coming to this, doing a lot of volunteer work, and they're coming to this with really big educational debt. So how does that put people who are from an underrepresented group, what kind of situation does that put them in when they're doing volunteer work, when they have high educational debt, when they're not compensated fairly, and so on? It really puts them at a huge disadvantage, and it's very, very discouraging. And so this is where a lot of my work has been focused over the past couple years, is really looking at compensation and debt. And especially debt. You don't hear very much about debt as it applies to these other things. You hear about it when people talk about choosing a specialty, more procedural specialty or primary care or whatever, but you don't really see it framed in this other way in which we're looking at what is it really like to be a woman physician or scientist in medicine in terms of educational debt, compensation, and promotion. And so as we think about this, this is one of the things I'm so glad that the dean is listening, because I think this is a huge, huge issue that we have to really think about more as we think about people who are underrepresented in medicine. And so thinking this through, when we have different advocacy angles that we can take for DEI, we can talk about patient care. And I will say that the literature is not very strong regarding patient care in terms of we should treat women better because women take better care of patients than men do. The research really doesn't support that. There's a little bit of that with regard to heart disease in terms of women's symptoms and so on. But the literature doesn't really support that. And there's not a lot of literature on that. And I'm not even sure that's the right approach to take, to say one group is better than another group. So the patient care advocacy angle doesn't work well, with the exception of making the financial argument, which is actually the strongest argument, that we need a healthy workforce to take care of all these patients. The ethical argument is really, we need to do this because it's the right thing to do. And that's true. And the dean brought up professionalism. Yeah, part of professionalism is being ethical. And of course, we need to do this because it is the right thing to do, because we believe that equity and fairness is important, and because we're ethical people, and professionalism is part of that. The biggest way to get change, though, is financial. So if you can drive home the financial reason, that's where you're going to get movement. So always go with the financial if you can. So let's talk about what happens when I give talks. People kind of break down into two groups, and this is very general, but they break down into the group that says women should, and they break down into another group that says leaders should. The women should group is the fix the women group. They want to fix the women. The women the women aren't quite right. They have a problem. If we could just fix the women, things would be better. The leaders should group is let's fix the system. Let's fix the structures. Let's fix the processes. So, most people who do DEI work do not believe the women should or the fix the women type of philosophy. And I can always tell which group someone belongs to when they start their sentence with women should versus leaders should. So let's take a women should approach to this problem. This is an international problem. It's called queuing, and women who are impoverished. So women have time poverty. They wait in line way more than men wait in line to go to the bathroom. This is an international problem that's actually super simple to solve, but apparently people have not thought it's very important to solve because we don't apparently care enough about women to solve this problem. So let's take the women should angle. Women should go faster so we can make them not menstruate. We can surgically do that. We can hormonally do that. We can say to them, let's not have them take their kids to the bathroom. Their kids are on their own. They can figure it out themselves. There's different ways to speed women up. But that doesn't seem like the right solution. What if we fix the structure? What if we said leaders should, people who own buildings should, have design engineers think about throughput and how many stalls a structure needs to get people through. This is a simple engineering problem, people. It is really not that hard to figure out how to get women, through a bathroom situation just as quickly in terms of the line as men. So because this is such a big problem and it's such an international problem, it's a great example of how we just need to really change how we think and even how we talk. So when I show different things, I'm always thinking leaders should. And we want to avoid perpetuating myths like things are better because there's more women. Not necessarily true. Things may not be better. As I showed you in the Richter et al. Study for the New England Journal of Medicine, things were not better because we have more women. Holding the affected group responsible, that's where we say, well, women should, and it's their fault and they haven't done enough. And then preserving willful ignorance and just saying, I didn't know. I never saw those women standing in line. I had no idea. So a lot of the way that we have decided to solve problems is through task forces. And I serve on a number of task forces, and I do think task forces and committees are just fine. But I want to call this out because it's really, really interesting. When you have a task force or a committee and it doesn't have any funding and the people are all volunteers on it, or mostly volunteers, and they're not really getting academic credit. This isn't really academic scholarship. It's community and citizenship work. And there's no data. And so it's not really moving the bar. That is a huge drain on the faculty and on the faculty's, on the institution's resources. But that's the way that we really run a lot of projects. We've formed committees and said, oh, over there, they're doing it. And so one of the things that's been super interesting, and some studies have shown this, is that even while we have these committees and task forces, things are getting worse. So these are called diversity structures. These diversity structures can make things worse, not better. And part of the reason is because we're not following the data, we're not really looking at it. And part of the reason is because we're actually draining faculty time and resources to do this work that is not particularly successful, and in fact is making them lag behind in their promotion. So we have these 4 gatekeepers in academic medicine. So when we hire faculty, we know they have to get through these 4 gates. So let's talk about gate number 1, which is the medical school or the hospital. So that's the organization that someone works for. And that organization really is responsible for a lot of things, including compensation. So one of the things that I noticed was that women were talking a lot about compensation, and there were conversations like, well, it's because they choose to work part-time, or it's because whatever. And I started thinking about you know, the what we often refer to as pay gap deniers. So the pay gap deniers, and I thought, why are they denying the pay gaps? And I realized that some studies take into account covariates like part-time work and so on, and other studies don't. And when you do drill it down and you look at covariates and you exclude reasons like how many patients they see, how many RVUs, part-time work, and all this, and then you get down to it and you say that the only explanation for this really is a you know, gender-related pay disparity, that those are the studies we should really be focusing on and quoting and thinking about. One of the things I wanted to show, though, was that it was sort of an echo chamber of women doing this research for free and talking about this research. So I did this study where I looked at all the gender equity compensation studies for physicians over the past, over this time period. And I looked at who was doing the research. And so it was primarily women were doing the research. Most of the studies were not funded. It was primarily women that were citing this research in other reports. And it was primarily women that were tweeting about this research on social media. So it was women doing the research, citing the research, and tweeting about the research. And yet most compensation decisions are made by men. So that's a really big disconnect. And that helped explain, at least in my mind, some of the pay gap denial that's going on, which is in not being familiar with the science. So as we think about how we're going to solve problems, it's important to know that when you have a group or an idea, or a new company, whatever it is, that you get some people to surround you and they agree with you. And those are the people that are, the disseminators, the early adopters, they're super happy about it and so on. But you always have to get to the early majority. And this is really the technology adoption life cycle, but it's also organizational change. If you can't get to the early majority and then the late majority, then you can't really drive change. And you'll never get the laggards. So you got to just forget about them. You have to just say, these people will never change. They're not on board. It's not going to happen. Just don't waste your time with them. So the early majority, these are the folks that it's really important for the DEI work that you're doing, that you present more data and you spend more time with them. When you spend most of your time with the early adopters, the people that are already on board, the people that already think like you do, then you're not going to drive change as much as when you really spend time with the early majority and you say, listen, I want to show you some data. I want to really talk about this. I want you to really think about this with me. And that's where you start to drive change. The chasm is where most things die. You can't get from the early adopters to the early majority. So remember, that's where most centers and programs and ideas and everything else dies. They die in the chasm when you can't go from the early adopters to the early majority. So as we look at this literature, one of the things that we know, and this is the Lasasso study that was very interesting, we know that pay gaps start right out of training. Women are paid less than men. And so Lasasso looked at a lot of covariates, very, very well done study, very interesting. And the adjusted pay gap is about $20,000. And then we know as women navigate up the ranks, that even at the level of chair, that they are not compensated equitably compared to men. And so we know that they start out at lower compensation. That doesn't mean that any individual woman is underpaid or that any specific department. These are studies that are looking broader, but it certainly gives us the idea that we should be digging down and thinking about this individually in departments, in medical schools, et cetera. That pay gaps start at the very beginning and last throughout women's careers. And when we look at, I did this analysis for neurology. When we look at a pay gap that's not that big, it's $30,000. It's not like terrible. I mean, it's not great, but it's not terrible. And we think about that over time, that turns out to be a lot of money. And here's the thing about this study. I have this little arrow pointing to the blue, because the blue is in radiology. And in fact, men had the disparity there. So keep in mind that pay gaps can go both ways. And certainly, you know, if there were lots of women, you know, predominantly women in leadership positions, and they did things the same way that, you know, have been done for them, then men would have huge pay gaps in the future. And that's not what anyone wants. I mean, that's not how we want to, establish ourselves as leaders. We want to treat people fairly. So, a big message from me is don't do, you know, to others what's been done to you. So when we look at this and we say, wow, it is a very conservative analysis that I personally did and published in the Journal of Neurology, very conservative, not investing a lot, investing very conservatively, et cetera. We're talking about a $30,000 pay gap over your career, ending up being in the millions of lost income and revenue and savings and investment. Now, what about grants? This is another area, mid-career and early career, that we have gender-related pay gaps that we can't explain other than it's gender-related. They've looked at different covariates and tried to figure out other reasons why these pay gaps exist, and it really comes down to gender. So this is an important thing. We have some laws in different states. We have federal laws that don't help us as much as they should. And then states are trying to reinforce that. But at the end of the day, asking somebody who is just out of training to negotiate their way to fair pay, when, negotiations are really about having a power position. So when we're talking about people who are underrepresented in medicine, especially trainees that are just graduating, that's not a power position. And so trying to put it back on them, like you should, women should negotiate better, women should, instead of leaders should pay people fairly. There's a couple options there, right? So I'm going to advocate for the leaders should. And, a lot of people come to me and they say, well, in our department, we are so fair because we do RVUs. And, RVUs aren't fair either. And when you look at the literature, you see that for urology, when there's a penile biopsy, you get paid a lot more than in OBGYN when there's a vaginal biopsy. Now, is a urologist really doing a lot more work than a gynecologist? No, but there's a lot more men in urology and a lot more women in OBGYN. And, this study is a really interesting one to think about. So what about if we base compensation, at least in part, on what patients think of us or on what our colleagues say? Is that fair? Probably not. There's a lot of literature. I mean, a lot of literature that says that women and people underrepresented in general, not only in medicine, underrepresented groups, fare poorly on surveys. And so I think that we have to really take a step back from this idea that we're going to use surveys to base pay on. And when we look at this systematic review, and we look at gender bias and we see how it starts in training, and we think about, oh my goodness, I often use zeros to really get people to say, oh my goodness, or aha, or that can't be so. So this is an aha moment, I hope, for some of you, to basically say, how could it be that men outpaced women 100% of the time, and women outpaced men 0%, not in a single category? Like, how could that be? So because this is such a well-known issue and the literature is so strong, this university decided to do this study where they put a simple intervention stating that women and racial and ethnic minorities are often receive lower scores that can only be related to gender or race and ethnicity, and to keep this in mind as you're filling out this survey. And lo and behold, the scores went up for the women professors, so compared to the control group. This is a gender bias calculator that basically you can put a letter of recommendation or other document in, and you can see how much gender bias is in the letter. This is another way that we look at unconscious bias or implicit bias, which is that often women are described as, oh, she's really empathic. And then, you know, for the man, oh, he is a great scientist. He gets grants and he does this, this, and this. So it's more, you know, hard skills and more skills that are highly valued. And believe me, I always hear back, well, empathy is really valued too, and so on. And, you know, when you're getting hired, you get hired more so for your hard skills than your soft skills. So soft skills are like empathy and compassion and things like that. And hard skills are like grants you brought in, you know, being an epic super user, things like that, that are documentable. So looking at this pay gap in medicine, we expect it to get worse. It already is getting worse for women because of a lot of factors. So this is really important to be thinking about. I start with compensation because compensation is about, you know, one of the most important things that people think about, et cetera. And, you know, trying to be part of the solution as an individual is really to amplify the work of women and individuals who are underrepresented in medicine. And I'm going to pause. I do see that we have a question. I'm going to pause before we get to gatekeeper number 2.
The question, Dr. Silver, was really an internal question about whether we as a college have collected any data around our graduates' initial salaries with regard to gender, which we have not, but I think that's an excellent idea. But I also think compensation studies within the institution are another excellent idea.
Definitely. And most institutions, you know, will show some problems. I mean, it'd be really hard to believe that an institution had no problems. And I think that faculty will generally accept that there's problems and there's gaps. And they really like it when they see the problems and then there's a plan to try to fix them. So, you know, the idea that any institution is just paying everyone fairly and compensation is totally fair and so on is just, that's not aligned with reality. That would be really hard to achieve. For men and for women, there are, you know, when Google analyzed its data, it found some problems with that when men weren't being paid fairly. So, you know, there can be problems, you know, on both sides, but it's almost always affecting the women, almost. So there are ways to look at compensation, and this is a structured compensation plan, looking at how people are compensated. And then this is Keith Lillimo at Mass General, who you know, really talked about this idea of, you know, it's not the pipeline. It's not that we don't have enough women who could be promoted. It's not that we don't have these very qualified people. It's, you know, there's a process issue. So I want to talk a bit about medical societies, because what happens when we have faculty is we send our faculty over to the medical societies and we tell them, you know, from the time they're in training, we say, look, you need to go over to the medical society, you know, participate in committees, give talks, do a poster, you know, all these different things, and then put it on your CV when you're a faculty member, and then that's how you get promoted. So now remember, I started with that Richter et al. Study that said that women are in 35 years haven't really made progress getting promoted to full professor and associate professor, right? So as you think about this, you say, well, what's happening over at those medical societies then? Because we are paying these medical societies to support our faculty. And you know, your institution is probably paying medical societies millions and millions of dollars. I mean, millions. And that money's also coming out of your faculty's pockets and your trainees' pockets, because most of the time we have professional fees and allowance, and it doesn't cover everything. So it comes right out of their bank account. So this is criteria from Harvard, and this is how you get promoted to full professor. And the way you get promoted is to give, you know, invitations nationally. Speaking of invitations nationally, well, you have to do that, you know, usually at the medical society level. Leadership roles in national, you know, professional organizations, national committees. I mean, you can see where this criteria is really a template for go to the medical society, do these things, and that's how we can get you promoted to full professor. So as we think about this, and remember I said that the financial argument's always your strongest. So what can we say about the finances? This is super interesting, and it's something I figured out as I looked at gatekeepers. The money flows the opposite way for medical societies. For everything else, the money flows to the institution and to the individual. The only way the money flows the opposite is to medical societies. And that means that we have power. So in the Her Time Is Now campaign, one of the things that I did with that is we have a dean and chair pledge, and we ask deans and chairs to pledge to support, financially support medical societies that treated their faculty fairly. So that is a really important thing that we can think about. So let's look at medical societies for a minute. So we looked at this and basically said, okay, here's recognition awards. And this is just one medical society. Men got a lot more recognition awards than women. And this is a medical society that has 42% women in academic medicine. Then I looked at another medical society and I saw for the past 4 years that 0 women physicians got awards. The most recent 4 years. And imagine thousands of women sitting in the audience, thousands of people sitting in the audience. And man after 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 man, year after year after year after year gets awards. That's really hard to understand, isn't it? So I hope that this slide is another aha one for you, that you say, how could this happen? Well, we had this concept, you know, when we submitted this study, the reviewers, they didn't like this. A couple of them gave us a hard time. They said, you know, this isn't a quantitative study, turn it into qualitative. No. 0 is a number. 0 is definitely quantitative. And then they said, well, we want you to do statistical tests on this. And we had a PhD biostatistician on this study, and he said, you can't do statistical tests on these zeros. That's ridiculous. But he said, there's this concept that the US courts use called the inexorable 0. And it's gone all the way up to the Supreme Court. The inexorable 0 is when there's a real 0, a true 0, or near 0 number, and you can't explain it any other way than discrimination. And so what the courts do is they have a prima facie and on its face inference of discrimination. So when you see an inexorable 0 in a court case, a judge can flip the burden of proof from the person who's suing to the organization. So the organization now has to prove they didn't discriminate because there's an inference, a prima facie inference of discrimination. So rather than doing recognition award studies, you know, going on and on and on, which is not what we wanted to do. We wanted to show that medical societies weren't treating people fairly. We decided to just go after zeros. And so we decided to show in all these different specialties, all these different zeros or inexorable zeros, and start to have people say, wait a minute, how did we get so many zeros? Like, how can this be that we have sat here for years and only watched men receive these awards? And then, of course, as we did this research, then people said, well, women should nominate women, which is silly. That's on the fix the women and women should do more kind of thing, especially when a lot of nominations come from deans and chairs and so on. So we looked at this though, in terms of causality. So this gets at causality. Is it that women are not being nominated? So is that the fix? And what we found in the early careers is that women were nominated, but they just weren't selected. So that's not a nomination issue. That's a selection issue at the level of the committee that's selecting. And on the mid-career, no women were nominated. That's super important because we put a huge number of resources into early career folks now. And we have a lot of women who need support who are mid-career. They needed support 10 years ago, 20 years ago, they didn't get it then, and they really need it now. No one, not women, not men, no one on the gender spectrum nominated women in mid-career. So, you know, I just say for any award in medicine, there's more than 0 women who deserve it. Now, what about, again, still staying with medical societies, what about presidents who are leading them? In this study, what I showed was that 10 medical societies had 0 years of women's leadership. 0 years over the period that we looked at. And 4 societies led the way. So we knew it could be done. And then we knew that people would say women don't want to run for office. They say women should step up more. Women don't want to run for office and so on. When I have a large audience and I'm speaking in person, I'll ask people to raise their hand and say, okay, how many women in the audience, knowing by the data that a woman's never been president of this medical society, how many women want to take time out of their clinical care and so on and do all this work, campaigning, et cetera, only to probably be defeated if you look at the numbers. So, and almost no one raises their hand. They're like, I'm not going to do that. That's just a setup for failure. Why would anyone want to put themselves in a situation like that? Frequently, 1 or 2 people will raise their hand and say, I'll break that glass ceiling. But imagine if we did that a different way and we said, okay, we know this vaccine is out now, but it doesn't work for anyone. Do you want it? It's like, who wants to take a vaccine that doesn't work for anyone? Who wants to run for an office where they never have any women? Men. And so, we looked at this study, we did a survey, and we realized the truth is that women need a lot more support in order to be successful, that it can't just be on the individual woman to raise her hand and step up, that's not really a reasonable expectation given the history. We looked at speakers at medical societies, and one of the things that we found here was, again, women are underrepresented as speakers. They're frequently underrepresented at the highest levels in the lectureships, the named lectureships, and so on. We also saw a little bit of a swapping out of women physicians. So women physicians are at a little bit more of a disadvantage than women with other degrees. We never want to lower the number of women in general. We always want to support women who have non-physician degrees because they're wonderful speakers and so on. But it's really interesting to see that women physicians, are not valued quite in the same way, even among women. So, there's a really important thing to think about with that in terms of supporting the women physicians in the clinical faculty. And just, looking at even in pediatrics, a specialty that has many more women than men, they have these problems. This is important because this idea that things will improve as soon as we have enough women, as soon as the pipeline's big enough, it has been disputed time and again by study after study after study. Things don't just get better on their own. It's not a matter of not having enough women. So I want to really highlight this issue. We've been focusing so much on our trainees, and we really should focus on them. But boy, do we have a lot of work to do with our mid-career and our senior women. We really need to have specific strategies around them. And the strategies around them should not be, highly qualified women need more mentoring. That's far too dismissive, and that's really disingenuous. Many of these women do not need more mentoring. They need opportunities. They need sponsorship. That is not the right path to take to tell highly qualified women that they need more mentoring. So, be part of the solution again, recommending them for awards, et cetera, thinking this through. This is just a simple strategy. It's not the whole thing, but, kind of thinking about what an individual can do. Micro inequities, we see these everywhere. They're little grains of sand. People often get really upset about it. And then someone says, wait a second, that's just a little grain of sand. Like, why are you so upset? And it's because there's such an accumulation. So you have to be careful with micro inequities or microaggressions, because a lot of people are only seeing that one grain of sand, and then other people are seeing all the grains of sand. So, the manels, the male only panels are very common. And this is, with COVID and the pandemic, there's been a bit of a tendency to say, move aside, ladies, we've got this, and have lots more manels. And, so this is really important to be thinking about and making sure that we adhere to our values and the idea that manels are really not okay. And we found in a micro inequity study that we did that over a 5-year period, in more than a third of the newsletters, women were left out 100% of the time, and men were never left out. So there's small things, you know, highlighting someone's work. Whenever I bring this issue up, because it still happens, I'll get an email back, Dr. Silver, you can suggest more women to highlight and feature. It's like, but that's not my job. That's actually your job. All right, so micro inequity mindset is just something that we take for granted, that we basically say, oh, this is just the way it is. And we walk by walls of you know, men on the wall without having women or racial and ethnic minorities, or you know, we walk by bathrooms that are with long lines of women, and, you know, just things that we take for granted. And we say, wait a second, why are we taking that for granted? Why is it that way? It shouldn't be that way. So gatekeeper number 3, medical journals. This is something, this of all the problems that could be solved, this one could be solved. And here's why. Because we have more than 20 years of research on this. For 20 years, people have been publishing on this issue. It's a really easy issue to solve. All you have to do is invite a few more women to be on the editorial board. So the fact that this problem that's so easy and inexpensive to solve, and the fact that there's more than 20 years of research documenting it, and the fact that it hasn't been solved by many journals is really the only example that I can find of a lack of a will to change that is so flagrant. This absolutely, of everything else, shows a complete lack of a will to change for those journals that still do not have good representation. And so, you know, I've been really going after this. In my research, I look for tipping points. So the recognition awards and the leadership, presidential leadership at medical societies are tipping points to try to get medical societies to be more fair to all of these faculty. And this editor issue is a tipping point for journals to start saying, wait a second, we need to be a lot more fair in a lot of areas. And we've got to start with this really easy problem to solve. And when we see like the attrition of women from academic medicine, this is one of the things that we can look at and say, come on, if you can't solve this super easy problem that has 20 years of documentation, then how can you possibly solve anything else? I mean, really, what confidence can we have that anything's going to be solved if this one can't be solved? So I've been really focusing again on this tipping point and calling it out and saying medical journals have got to do this, and we have to hold them accountable for this. And the journal Neurology has a new journal editor, and he said, yep, I'm going to do it. I'm going to do it now. And he laid out this plan, and here's what he's doing, and he's going to address race and ethnicity next. So it really is doable. This is not something that's impossible. This really has to do with committing to data-driven diversity, equity, and inclusion. Gatekeeper number 4, funding agencies. I think that this is really important because, you know, again, it's part of navigating academic medicine. And this is a really important one for institutions, because when institutions, the more he for she a dean is, like your dean, the more a dean is committed to diversity, equity, and inclusion, the more the investment in the early career and the faculty will be for that institution, the worse it is if the other 3 gatekeepers are not fair to those faculty. So it becomes financially, again, financially, it's a poor return on investment to invest in women and diverse faculty if the other 3 gatekeepers do not treat them fairly. So the deans and the chairs have got to insist and push the other 3 gatekeepers to treat their faculty fairly in order for them to realize their best return on investment. A quick minute here talking about sexual harassment. I know you had a whole talk on this. I want to talk about it just very, very briefly. In medicine, we have a really big problem with sexual harassment and gender-related harassment, which are not the same, but they are in the same family. And we know that Dr. Collins came out and said, look, this is ridiculous. You know, we've been part of the problem. Now we want to be part of the solution, and we're going to try to do better. When I started talking about this, I saw all these men in the audience, their eyes kind of get big and they were just really upset. And a lot of the conversation felt like we were saying that most men in medicine sexually harass or participate in gender related harassment against women. And that's not really the way it is. The way it is that we have a few people, primarily men, who are serial perpetrators. And we have not dealt with these serial perpetrators, and they affect many targets. And I want to reframe the conversation because I think it's super important to call out that most men in medicine are good people. They don't sexually harass and they don't participate in gender related harassment. But they have failed women terribly in that they have not gotten rid of the perpetrators who have then gone on to have many, many targets. So very important to make that distinction. Equity, diversity, and inclusion, really, we should look at it and data-driven, and this is a cycle of just looking at the data, analyzing it, doing interventions, looking at the data again, et cetera, the way we would solve any problem in medicine, safety, quality, et cetera. This is the AAMC gender statement, or a statement on gender equity. Leadership and compensation is a key priority here. Lots of papers and different reports that will help with this gender equity. And again, in these reports, including from the AAMC, they're charging deans and chairs with taking ownership of these issues and saying, this really is, this is a leaders should issue. Leaders should be responsible for these things and take responsibility for them. So I know that you were looking at sort of like, how do you hold different groups to a higher level than you've held them before? And I think, this is from the Be Ethical report that I wrote, which, kind of helps people see in this, really ethical way, how data-driven it is and how focused it is, and trying to get to that truly ethical component. Ethical leaders do use science to advance gender equity. They don't promote myths. They don't blame women. In the Her Time Is Now campaign, we focused a lot on some of the issues that have come up, including compensation and promotion. I didn't focus on federal funding for the Her Time Is Now campaign. I do these national initiatives every year around my Harvard Women's Leadership course. So every year I develop a new one. This past year's was Her Time Is Now. But if you're sitting in the center of this Venn diagram, you have a lot of barriers. And we have got to remove some of those barriers for you. We really do. This is just absolutely super important. And I wanted to show again, have people have an aha moment where they said, my goodness, how can it be? I took the AAMC data and I converted it to percentages, again, looking at zeros and inexorable zeros. And I defined the inexorable zero as 0 to 1%. And basically showed that for Black and African-American women and Hispanic and Latina women, there's inexorable zeros for the professor level promotion in almost every specialty. That should just make you stop and say, oh my goodness, that is absolutely insane. Like, how can that be? And how could we possibly be recruiting these folks and saying, yeah, we're going to promote you all the way to professor, although other people have never gotten there, but we're going to do that with you, when we have the Rick Direct All study over 35 years that say we didn't promote the women to full professor. That's not true. We can't say that. It's not true. So what are we doing in our department? A lot. And not enough. No one's doing enough. There's so many problems to solve. But I'm here talking to you today because our department does have a commitment to diversity, equity, and inclusion. We are engaging as many faculty as possible. We are publishing in a lot of different journals and getting the word out. And we're doing it on workforce and patient care, really trying to lead the way, understanding there's an intersection between these two things, and just trying to really be a model of scholarly best practices, data-driven DEI. Thank you so much for the opportunity to present to you today, and I'm happy to answer any questions if there are any.
We do have a few minutes, so if anyone has any questions or comments that they would like to share, feel free to type those into the chat. We are monitoring that. I'll just give a couple of moments while we wait to see if there are any questions. Wow, thank you. I really want to thank you for taking the time to enlighten us today. I think it's been pretty insightful in terms of thinking about the state of equity, diversion, and inclusion in academic medicine, and I think a really good motivator to, really see how far we've come, but also how far there is to go and how much work we have in this.
Yeah, absolutely. And I think, one of the things that I've been thinking a lot about is the model of having one person or two people or whatever who are paid to do DEI work. And then their job is to enlist a lot of volunteers. And the volunteer workforce comes from our faculty workforce or our staff workforce. And for many institutions, though not all, everyone is paid a salary except the physicians. So the physicians lose clinical money, they lose clinical revenue. So that puts them with their huge educational debt, that puts them deeper in debt to volunteer. So I think we have to really consider how we're, how we're engaging all these volunteers. And one thing that I've asked in terms of the different people that come to us and say, can we have someone from your faculty, from your department, et cetera. One of the things that I've been really asking for is, number one, is there going to be some publishable product coming out of this, a paper, because faculty need to publish to get promoted. The second thing is, have you hired a writer and a biostatistician for this, so that you're not asking our faculty to write a report or to do statistics? They can be the true subject matter experts and take a lot less time. Once you saddle a group of volunteers who are women and underrepresented in medicine individuals with writing a big report, doing lots of stats, et cetera, you've drained a ton of their time. So really rethinking our volunteer workforce, giving them credit, getting them publications, et cetera, and not draining their time and effort, but still keeping them front and center.
Thank you. That's helpful. I think we do have a couple of questions that have come in here. One is advice for mid-career women at this institution. So who have experienced these barriers? I was told by HR we have implicit but not explicit bias here, and there's not a whole lot that we can do about it. Thoughts on, certainly we have ideas here at our institution. What about at your institution? What have you noticed?
So let's just define implicit and explicit bias so people know, everybody knows. So implicit bias is unconscious and explicit bias is conscious. So no one's going around at your institution saying, we don't want to support women, we don't like women. So that's great. I don't know, that's kind of a low bar, but okay. Implicit bias is unconscious. There's tons of ways to uncover unconscious bias, lots and lots of studies. And that's what data does. Data uncovers the implicit bias. So I would never accept anyone telling me we can't do anything about implicit bias. Of course you can. You can study things and you can look at them and you can show people the results. And then you can say, wait a second, look at these surveys. Women aren't getting graded as high. That's a problem. You can tell, show that to your medical students. All kinds of ways to look at implicit bias. And, and what we do at our institution in my department, what I try to promote is looking at data.
Okay. Gathering data.
Yeah, gather data, look at it and act on it. Act on it. And then gather it again. Make sure that what you've done, and don't wait 35 years. That's so painful. That study killed me. Oh, that was so painful to read.
Yeah. Quicker turnaround time there.
Yeah, exactly.
And one last question. Do you think it's possible to apply what's been learned in regards to gender equity among faculty to the process of reviewing and reporting on staff equity as well?
Absolutely. There's so much of what we have studied in medicine has been on physicians and scientists and faculty, because that's where the data has been collected and so on. But keep in mind that medicine in healthcare is a huge sector, but then there's all these other sectors. And so there's a ton of research on just women in general or underrepresented individuals from different, from different realms, whether it's race and ethnicity or disability, et cetera. So it sits in a much bigger pot.
Mhm.
So the kinds of things that we know, can work in general, like paying women fairly, like having, that works for staff as well as it works for anyone else. Those types of things, and any kind of recognition awards, and just lots of things like that you can look at.
And actually, I think that is a great segue. Our time is up, so I want to thank you for your time. I want to thank the audience for all of your time, Dean Page certainly for his support. But I think the recognition piece that you talked about, that this is a great way for me to remind everyone who's watching now to please submit nominations for our Celebration of Gender Equity Awards. There are awards for both faculty, staff, as well as students. Submissions are accepted online through January 15th. So please do that. That's perfect. Thank you. Thank you everyone for joining us.
Thank you. Have a great day, everyone. Take care.